Great. We are here for N693 WHGNP for April 15th, 8 a.m. to 12 p.m. There are 3 cases. Each of you has been assigned one of those cases and has your case materials already. There's an IUD case, an osteoporosis case, and an anencephaly case. Each of you will see each of the students. Each student will see all 3 cases in the course of their time in SPL that day. Let's start. Well, dealer's choice, Erica. But I'm going to go ahead and turn it over to you.
Okay. I think we'll start with osteoporosis since I think we have the most live in-person people for that one, and that way they can move about their day. And so I'm Erica Springer. I am faculty and director for the Women's Health Nurse Practitioner program here at Drexel. To give you a little bit of an overview, our students are coming to campus for their last on-campus intensive. And so they've been practicing in clinical for almost a year now. So they should be pretty well versed at things like history taking. They are also going to come in with some more background information than I usually give for standardized patient cases. So they'll have like a medical record with some of your background stuff. So don't be surprised if they don't ask a lot of questions about your medical history like you've maybe experienced in other SP cases because of the way that this is laid out. The whole overarching theme learning objective is for them to gain confidence in their transition role to an actual women's health nurse practitioner out of that student role and into the clinician professional role. So these 3 cases are designed to give them kind of the gamut of things across the lifespan, from childbearing with the anencephaly case to procedures to a postmenopausal osteoporosis case in primary care. So it kind of catches a little glimpse of each of the things that a women's health NP may incorporate into their day. And so their ability to kind of flex between cases and go from one content area to another. I am very much available. So if between now and next Tuesday, when we run these cases, if you have any questions, please don't hesitate to reach out to me with questions. My email, I'm sure Chris will share, but it's eks45@drexel.edu. So the I will share my screen. Don't forget that. All righty. So the osteoporosis case is actually considered a medication error case. And while we all try our darndest in healthcare to do everything absolutely perfect, at the end of the day, we are all human. And especially as a new NP, and any provider, we have to know if there's a patient who questions us about something, or if we actually make some sort of an error, we have to know what the proper way to handle that is, best practices. And the other piece that I didn't share is that we have a handful of law students that are going to be joining us. So you may have an extra bystander in the case that's kind of just hanging out and not actually part of the case. So I know that creates some awkwardness and lack of authenticity, but it's pretty hard to incorporate a lawyer into a medical environment without making it something that we don't want it to be. But it's really helpful to them. We've learned over the last few years to actually be part of that and see how clinicians operate in practice. And then we have really neat debriefing discussions afterward. So if there's an extra body in your room that is a law student, you can just kind of ignore them. So the cases each are 20 minutes. You'll have 5 minutes at the end of each case to give feedback to your learner. And then there'll be 5 minutes in between the cases. These are going to be recorded just so that what I find is our learners, when they go to watch their recordings, they see that they know more than they felt like they did. They're much less nervous on the outside than they were on the inside. They have much more confidence. So that's kind of the intention behind. And the feedback that they're going to get, I'm not going to watch them as faculty. I don't have a checkbox or I'm not grading them. This really is, the value of the feedback that you give as a patient, because there's really no other environment where I get direct real-time feedback from my patient on how I can improve my mannerisms and my care. So they will get to do this pre-visit chart review. They have to know about osteoporosis, the risk screening, treatment, and referral. And they have to be competent in practicing as a clinician. And then they also have to demonstrate ability to react when there's an error that they themselves actually made. Age of SP is over 45, so postmenopausal is the really big key here. In terms of skin tone, if you are darker skinned, you can just kind of ignore all of those prompts around it. Those with less melanin in their skin, those with fairer skin are at higher risk for osteoporosis. So just something to keep in mind. And so this patient, you were seen by this nurse practitioner for your annual well visit about 6 months ago. And the nurse practitioner, they noticed some things, and we'll talk about your medical history, but they noticed some things that put you at higher risk for fractures. And they got a little bit overzealous after getting a DEXA scan. And the DEXA scan is actually an X-ray image that indicates how dense the bones are, right? So bones are kind of like a sponge. And if there's bigger holes in the sponge, the bones are less dense and puts people at higher risk for fracture. This happens as we get older, as we lose estrogen and menopause. So it's a screening test that we do. Normally we started at 65, but we did it earlier for you, which was the right thing to do. Because you have, again, in your medical history, I'll kind of point out those things that put you at a higher risk for osteoporosis. Where the challenge came that was when the student got the imaging results back, the DEXA scan results, it indicated something called osteopenia. Back in the day when these medications for low bone mass came out, like Fosamax, we gave them to everybody whose bone mass was even slightly low. That's not the case anymore. We've become very much more careful about who we prescribe them for. And so the student gave you this medication and you didn't need it. What you really needed was diet and exercise and calcium and strengthening and balance exercises to prevent fracture and some repeat screening in a couple of years. Well, these medications have some risks, and there's something called spiral fracture, and they have side effects, which are mostly gastrointestinal, and that's what kind of prompted you to look into this further. You're getting some side effects from medication, you have worse reflux and heartburn, and so you did some internet searching on your own, and you realized, and you have your patient portal, so you've seen your DEXA scan results, and you put together that you're like, wait a minute, I probably don't even need to be on this medication yet. And I'm taking a medication that has all these scary side effects or scary risks and is causing me side effects. So you come today to approach this provider to share your concerns, and you're not real happy about it. You're not absolutely belligerent and screaming at the student, but you really want some answers from them. And the goal really is to get them to disclose it, like, hey, Miss Rhodes, I'm really sorry. Based on some risk factors, I decided to do this. I get that this may be over treatment. And yeah, I think it's okay for us to discontinue the medication. That's the absolute goal. And it's to make my students really think like, oh crud, like I did something wrong here. If I make a misstep, like how do I recover from that? So we kind of went through that. So your opening line is, I'm getting heartburn since taking the Fosamax you prescribed. I looked at my DEX report in the portal. I did some research. I don't even understand why I'm on this medication. I don't actually have osteoporosis. So my students should look a little bit uncomfortable with this. Your medical history, and I'll come back to the challenge questions. You have celiac disease. This is a gluten allergy that causes a lack of absorption of calcium and puts people at higher risk for osteoporosis. So you manage it though with a gluten-free diet, but it does put you at increased risk. So your allergies are gluten. You're also allergic to penicillin and seasonal allergies. You take an Advair discus, an inhaler, which is a steroid, and that can increase your osteoporosis risk as well. And that's one puff every 12 hours for asthma maintenance, and your asthma is well maintained on that. You haven't needed to take any oral steroids ever. The alendronate is the Fosamax, 70 milligrams once weekly, and that was prescribed by the student who you're seeing today. Surgery, you had your gallbladder taken out in 2001. You've had 2 vaginal deliveries and no complications in your pregnancy with high blood pressure or diabetes or anything like that. Incidentally, you've had your 2 COVID vaccines. If they ask about a menstrual history, you started your periods at age 12. And you went through menopause at age 43. And this is really important, this early menopause before the age of 45, because that, again, is another risk factor for osteoporosis. So that's a really important medical history point. Obstetric history, this is just how my students might talk about it, been pregnant twice, like we said, and you had 2 term deliveries. So G is number of pregnancies, P is number of deliveries, and 2 means that you have 2 living children. Contraceptive history, you used condoms until menopause, not super related, other than you weren't on any sort of hormonal birth control. History of STDs, chlamydia back in 1996, which was treated. Started having sex at age 17, 3 life male partners. So just in case my students, sometimes they go down a deep dive of medical history. And this stuff, if you don't have the details very specific, it's not the end of the day. Again, kind of really those risk factors for osteoporosis are the most important parts in the medical history. Your mom is 82, she's alive, she has high blood pressure, and she has osteoporosis. So we have this family history piece here. Your father, unfortunately, passed away at the age of 86 from COVID back in 2021. You've been married for 32 years, you're a homemaker, you used to smoke, again, another risk for osteoporosis, but you quit 4 years ago, good for you. No drug history, and you have 1 to 2 glasses of wine per week just socially, so no issues with alcohol or drug use. Psychiatric history, you had some acute anxiety when your dad died, but you're no longer taking any medications. You did use some anti-anxiety medication as needed at that time, and you're still seeing a therapist twice a month. So challenge questions. I was talking to my friend and looking on the internet. I keep seeing to get a DEXA scan at age 65. Why did I have the test already? So this is a really important question because I want the student to be able to verbalize what the screening parameters are for osteoporosis and why they made a decision to order this test earlier for you. And again, celiac, early menopause, family history. If you're fair skinned, that could be another one. If you have light eyes and if you have a petite stature, those are all other things that we see in increased incidence of osteoporosis. And then your other big challenge question really that you need to press them on is the internet said the meds are only given for osteoporosis. I don't have that. Why did you give me this? And at this point, the student's expected to handle the error disclosure saying, hey, I overtreated. I totally get that. I'm sorry. I was looking at your risk factors, whatever that is. But at the end of the day, they should be apologizing to you in some capacity. And that is an accepted thing to do. In terms of age, you can use your own. I think we went over most of this stuff. Oh, this is weird that is different from what it says above, but I don't know why. I don't know why I have this in here twice. So anyway, mom's still alive. Any questions? Oh, in terms of feedback for our learners, so making sure they're professional, they're introducing themselves with name and title, did they make eye contact? Did you feel comfortable in the setting? Did they acknowledge the error? So how did they react when you kind of called them out saying, hey, you're over treating me and now I'm having side effects and these medications have risks? Did they handle that well? Did they own it? Did they try to pretend it didn't happen? Did they justify their actions? Did they try to make excuses? Did they try to blame someone else? So like, how did they handle that? And really they should own it and apology is acceptable. Did they come up with a care plan for you? So after this error disclosure, were they able to come up with a game plan? Because it's not like I give you meds or I do nothing, right? So did they actually do some education and teaching that was non-pharmacologic when you guys decided to not take the medication? The student should discontinue the medication. I would doubt that you would have anybody that would encourage you to stay on it. But if you do, I would encourage you to fight that and say like, no, I'm not going to take this medication that has these risks and side effects when we don't have a justified cause. Again, unlikely outcome, but if that happens, please, 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 like don't let my student keep you on this medication. You're not supposed to be on it. And again, did they talk to you about the non-pharmacologic ways and when are they going to follow up? And there should be a DEXA scan in about 2 years to make sure that it doesn't worsen. That's the osteoporosis case. do the IUD informed consent case. All right. So this is called IUD informed consent. The gist of this case, so again, the law students are there. So this is one of our key concepts in terms of what exactly is informed consent. How do we assure that our patients are fully like all the context pieces of informed consent? It's not just getting you to sign a form, which there will be a consent form should they proceed with inserting the IUD, but it's about informing you, making sure you know the risks, the benefits, what if you do nothing, and that you have decision-making capacity. And so that's really kind of the big question here is, are you impaired or not? And, you know, if you are impaired, can you actually sign informed consent? And that's kind of our legal discussion afterward. So again, 20-minute case, 5-minute feedback, 5-minute turnaround. This is an outpatient clinic. So you're here because you want an IUD put in, particularly a power grid IUD, because you don't want to take any hormones. You haven't dealt well with hormones in the past. In the past, you have been consulted by a different provider. So this is your first time seeing this provider that you're meeting today. And you've had some conversations about this, right? About what kind of contraception. You come to the agreement that a non-hormonal IUD is the best contraceptive method for you at this point in your life. You currently use condoms sometimes. And so that raises two things. A, we want reliable contraception. And we'll talk about kind of what your sexual repertoire is at this point that puts you at risk for unplanned pregnancy. And also, we have to think about STDs, right? On a side note, my student needs to be like, hey, if I'm putting this IUD in and this is the way she's having sex and she's not reliably protecting herself with condoms, then I definitely need to be super aware of that. So previously documented by a previous provider was full teaching and understanding of contraceptive options. And so my learner needs to determine that today in your capacity that you can sign informed consent. So I took the age out here because I know we have a broader range of ages. As long as you appear under 50, there is still a risk of pregnancy, and this is still a valid thing to do. You've been pregnant one time, you had a medical abortion. So P means you've had 0 actual term pregnancies and you don't have any children. You came today for your IUD. It's the first time my student or provider is seeing you. The medical assistant already got a urine pregnancy test, which was negative, showing that, you know, to our best knowledge, you're not pregnant today. So they come in to consent you for this procedure, and they get this strong smell of marijuana when they walk into the room. Your pupils appear dilated, and there's a little bit of a sense of impairment. So kind of things, if I scroll down, things to think about in terms of your overall demeanor. I really want the student to question if you're impaired or not. I want them to come to a point, can you make a decision to be fully informed in deciding on an invasive procedure or not? So that could be things like when the student's reviewing the risk of the procedure, you could change the subject. You could become distracted, like, oh, hey, did you see that bird outside? Like, just really, and I know I'm kind of stretching the reality of people who use cannabis in medical ways, but we kind of have to do that to make this case work in the way that we need it to, and to get to the meat of this informed consent process and impairment. Or you could do something like repeat. I know it's going to hurt, and just keep ignoring the other risk. So the student's trying to tell you there's a risk of infection, there's a risk of perforation. And you're like, I know it's going to be hurt. Can we just get on with this? Like, you just keep going back to like, just get it in, get it done. And you're not giving them easily that, yes, I understand what's happening here. You're not just repeating back to them, right? So I want it to be a moderately difficult consenting process. I don't want them to be traumatized by your challenge, but I also want them to really have to, the key is I want them to have to think, can this person, are they impaired from smoking cannabis right before they came into the office? Are they too impaired for me to actually legally get consent? Or and eventually you can come around and you can affirm them. How the disposition, whether they put it in or not, doesn't really matter as much as getting them to think about, is this person impaired or not? So your opening line, let's get this show on the road. I'm finally here for my IUD. So you showed up prepared for with your anxiety controlled by your cannabis to get this IUD in and never really thought, like you've talked about it, you've decided it wasn't on your radar that you would have to sign informed consent. Most patients aren't thinking about that. But my students, that has to be one of their primary goals when they're actually consenting someone for a procedure, is that the person, you know, has decision-making capacity. There is, in terms of the actual IUD, there's just going to be like a little fake uterus disc and an IUD at the bedside table. Obviously, my students have been reminded they're not supposed to you're not to undress or put anything in you. It is not that in detailed of a hi-fi simulation. So like if they decide to do it, they will practice on the little disc on the side table. So you're opening line, let's get the show on the road. I'm finally here for my IUD. You're sitting on the table. You're fully dressed with a sheet over your lap. That's going to simulate the preparation for the IUD. And again, kind of that whole challenging of behavior related to impairment. You can ask if it's going to hurt. If the student questions your cannabis use or impairment, you have a medical card. It's legal. You do it all the time. I can't believe you're questioning me. So you're actually annoyed that they would even question because you're so sure that you're fine to consent to this. But that's, you know, it has to be both parties have to believe that that is true. If they don't ask about cannabis use, be sure that you tell them that you smoked right before you came in to relieve your anxiety, right? So it kind of depends on how the student plays this as to kind of what your responses are. You're really trying to sell the student on putting the IUD in, regardless of what their questions around your impairment are. Your partner came out as trans 2 years ago, and you guys decided to have an open relationship. And so it's really, you never wanted children. You don't want children. You had an abortion once before. You don't want to do that ever again. And so you really can't get pregnant. And so this contraception, the risk of pregnancy is very real, and the need for contraception is very high. So you can ask questions or give statements to assure the student that it gives a clear plan of care and support to get an IUD, and that need for contraception for sure. Be aware of the student placing any unnecessary burden on the patient. And what I mean by that is like, well, I don't feel comfortable doing this because there might be a question of your impairment. So you're just going to have to leave and come back a different day and do X, Y, and Z, and making this big long list of things. So putting barriers between you being right there, the student's anxiety or worry about your impairment and having to make a decision, and then making it that you have to go wait 2 weeks and, you know, whatever steps they were to put in between you. And you can certainly call them out on that in a kind of kinder, gentler way, not in a combative way. But you really, again, you're supposed to push them and really get them to weigh that benefit of the contraceptive need versus their concern about your impairment. So age, as long as you appear less than 50, you can choose an age that is consistent with your appearance. The younger, the better. You are still getting menstrual periods. Your last one was about 9 days prior, and that puts you right in the ovulatory window. And that's important for when we're deciding if we have to be reasonably sure you're not pregnant. We also know that putting a copper IUD within 5 days of unprotected sex could act as emergency contraception and prevent implantation. So my students need to know that and kind of be able to do the math on the fly to see if that's a contributing factor to us being able to put in the IUD or not. You're not married, you're in a 4-year relationship with a trans woman who came out 2 years ago, and both of you have additional partners. Again, that risk for sexually transmitted infections. So at the very least, my students should be offering you STD testing. You work as a manager of a coffee shop. Condom use is inconsistent. No recreational drugs, but again, cannabis is a medical indication. You were in the hospital for an appendectomy. That's your only surgery that you've ever had. And we talked about pregnancy history, and you're really definitely sure that you do not want kids. So that's kind of off the table. There's no concern there. You know, what your decision is, that's clear as day. Your only medical history is asthma. And is there any chance you could be pregnant? No, you just had your period last week and you haven't had sex since then in a way that could get you pregnant. Your only thing that you use medication wise is medical marijuana for anxiety, and you smoke 1 to 2 times per day. And you smoked in the parking lot right before you came in because you knew you were going to be anxious for this procedure, not knowing that, I know I'm not very good at telling my patients not to be impaired when they come to their appointments and to sign consent. So it's kind of a lesson learned. Family history, everybody's healthy. Your dad has a history of diabetes. He takes medication and diet. And then mom has a history of high blood pressure. You have one brother, but you guys don't talk, so you don't know a lot about him. No family history of any genetic abnormalities. Never hospitalized, and no asthma flares for the last 10 years. Immunizations are all up to date. You're vegan, you walk daily to work, you use albuterol as needed, but that's rare. You have some seasonal allergies. I'm really inconsistent today. Not married. Goodness gracious. And no medication allergies. Um, no sexually transmitted diseases. You got your period at 11. Again, sometimes my students will ask questions and get like thorough histories because it makes them feel comfortable. Menses every 30 days. So you have regular periods, you get moderate cramping. Started having sex at 15. You have 9 lifetime partners, 4 in the last 2 years. 3 of those were male and 1 transgender female patient that is your significant other. Things to give feedback on. So they introduce themselves, they give good eye contact. They make you feel comfortable, basically. They speak clearly in terms that you can understand. So in lay terms, they're an active listener and their body language is appropriate. Were they empathetic to your situation? So even if they get to the point where they don't think that you are able to, agree to an IUD in a legal way, they should still be empathetic and respectful and help to create a plan that makes you getting this contraception as easy as possible. Did they ask you about any history or previous hospitalizations or allergies? Did they get consent? So did they discuss the procedure, the risks, the benefits, the type of device, and including the risk of not proceeding? And or if they declined, did they make a plan of care that helps to minimize your risk of unplanned pregnancy and also respects the medical use of marijuana? So, did they come up with a game plan that you could utilize your medication for your anxiety, but also be not impaired to sign consent, maybe coming in early to sign the consent and then wait, whatever that looks like. So that's up to the student and you. Things they should be doing is discussing the actual procedure, including risks and benefits. That's not negotiable, right? Like, so in consenting, risks not limited to infection, expulsion, and perforation. If there's a perforation, it requires surgery to remove. I am noting that Paragard can be used as emergency contraception within 5 days. Not a concern for you because it doesn't seem like you've had sex in a way that you could get pregnant recently, so not a big deal. And also, what to expect with Paragard. Periods can get crampier and heavier in the first 3 to 6 months. If it becomes problematic, they should notify the office. And then we should definitely do STD testing before insertion of the IUD today because of your sexual risk and inconsistent condom use. And last but not least, we have Miss Jessica Orlando. Same time frame of these cases, outpatient ambulatory office. So she's a young professional woman presenting for an acute visit. So she got added onto the schedule today. She's 21 weeks pregnant. She is healthy. She conceived on Clomid, so a fertility drug, and it's her first pregnancy. This is very much a desired pregnancy is kind of the key here. She had a prenatal ultrasound today and was excited to find out whether the baby's a boy or a girl, but instead the perinatalogist was called to inform them that the baby has anencephaly. And anencephaly is a condition where the neural tube, as development's happening, it doesn't close all the way at the brain and it impacts the cerebrum and the cerebellum of the brain. And so, the face forms, there's usually some malshapenness of the head, but the brain's never going to function in a fully cognitive way. And these, if the babies live to term to be delivered, they normally have a very, very short lifespan and are significantly impacted as their brain does not function for activities of living. So this is a very sad case. And again, that's the life of a women's health nurse practitioner, right? Like I could see a very happy pregnant couple in one room and then have to go deliver bad news in another room. And so the students are currently taking high risk OB. And so part of this case is them understanding what anencephaly is, and also how do they counsel patients when, the perinatologist is the expert in the um, prenatal care and the anatomy and physiology and that part. But that doesn't mean that we don't have something to contribute as a nurse practitioner from the psychosocial emotional component and support there. You're married to Michael. He's out of town on a business trip, so you're all by yourself, unfortunately. So I'm lacking some support there, but my students may ask if you have anybody else who could be supportive through these next couple of days until Michael returns home. So it is considered a lethal fetal anonymity because of the lack of brainstem development. So if the fetus lives to term, will most likely die within a few hours. And so the clinician really needs to create a space to discuss your understanding of the diagnosis and possible options for care. And most of the time at this stage, you just found this out today, you're going to be in denial and disbelief, right? So you're going to be questioning kind of medical procedures that they might be wrong, and really your brain's going to be kind of all over the place in terms of trying to hold on to this being a normal pregnancy when it very much 100% is not. So the clinician also needs to be able to recognize what you can handle as a patient versus, and also take into account your beliefs surrounding pregnancy termination, which we'll kind of get into. You really do have the option to continue the pregnancy or terminate the pregnancy. And so we'll kind of go through where that is. Sometimes in the medical world, providers tend to lean toward termination. And it's really important that we make shared and respectful decisions with our patients and make sure that we are sharing the option to continue the pregnancy, even though the end result is still not going to be a healthy living child. So 21 weeks, you were just excited to find out the gender, and then you found this out instead, and it's devastating. So your opening line, we had our ultrasound earlier today, and they told me there was something wrong with the baby. The baby had a strong heartbeat. I just don't understand, right? So they told you there was something wrong, and that's about what you got from it. And again, that's where having some space between the ultrasound, coming to the office, and having some time to kind of process through. Mostly the goal of today is to get you to just understand that there is a lethal anomaly with your baby and to figure out who your support can be. So I'll get to that. Medical history stuff. Have you ever had surgery? No, just through fertility. They did it's called a hysterosalpingogram, where they just do a procedure to make sure your tubes are open. And if you describe it as surgery to make sure my tubes are open, the student should know what that is. This is your first pregnancy ever. Very much desired. You're taking prenatal vitamins, no other medications. You're really healthy. You're a Catholic high school teacher. You had 2 years of fertility before conceiving. You come from a large Christian family. Your husband's an engineer. So, kind of gives a context of, not to stereotype engineers, but you have your own home. It's a very planned pregnancy. You had 1 glass of wine prior to a prior pregnancy test, and this worries you. You're thinking that perhaps the wine did it. It definitely did not. And so your questions, challenge questions, I don't understand. And the student should really try to give some expectations of what to describe with anencephaly. I saw the baby move. What do you mean my baby's going to die? I can feel him move now. So at 21 weeks, you're feeling fetal movement. So again, it makes it even more distressing to the baby. Doesn't feel different to you. We just now have this new information that you didn't have yesterday, and that's really hard to process. And you're really, as they try to explain, you're like, I can't believe that. They have to be wrong. Can I get a second opinion? What causes it? And you have this guilt about, is it my fault? I had a few drinks before I knew I was pregnant. Did I do this? You're very tearful and you're covering your face, at times, just because it's hard to handle this information and you just want it to stop and go away. It feels like you're in a nightmare. So the student, what do I do now? So once they get you through kind of some of the emotion and you're starting to take in that, yes, this is actually, a lethal condition, the student's going to explain conditions to terminate the pregnancy with a dilation and evacuation that is legal in Pennsylvania, even in mid-trimester for anomalies, still today, right now. And then they'll put some softening stuff to open the cervix that's going to cause delivery prior to viability. Or so you could either have a procedure, you could actually try to deliver this very preterm infant, or you can carry to term knowing that either stillbirth or death shortly after delivery is probable. And your response is get an abortion. I will never murder my baby. I saw him move. And you're very, very tearful and upset by this. So this whole abortion termination part with your underlying values around it makes it even more challenging because you said you'd never do that. And here you are faced with this condition where you're like, wait, my baby dies no matter what. This feels different, but yet you stick to your preconceived thoughts around that in the context of this case. The students should really emphasize that you have autonomy to choose with your partner how you handle this and how you like to perceive. And they should really encourage you to take some time. This is not an emergency. So the biggest thing is just making sure that you know, have the information to make the decision and you know what all of your options are. I think that's feedback. Do they introduce themselves with title and name? Do they acknowledge meeting under unfortunate circumstances? Because this is the first time you're meeting this provider. So it's one thing if you have an established relationship with me and I have to have these conversations. It's much harder when I've never met you before. Do they try to keep good eye contact? Are they comfortable with some silence, right? Like, so sometimes when patients are tearful, the best thing to do is to hand them a tissue or to just hold tight and let the patient process some emotions. And sometimes students try to get super smarty pants and tell you everything they know about a condition. And they're very uncomfortable in emotion or they're very uncomfortable with silence. And that's a really important part of delivering bad news. And do they recognize the difficulty of the diagnosis and the difficulty of the decision? So do you feel heard and seen and supported in this? Do they describe the fetal condition of anencephaly? Do they recognize the difficulty of bad news? Do they offer information? Do they educate you at all in a way you can hear it? And do they suggest some options of the treatment? So I want you to come away from this realizing as a patient that this is a lethal condition. The baby is not going to live happily ever after. There's no question about the diagnosis. It's not something we get wrong. So they shouldn't really be ordering extra ultrasounds and recruiting extra providers just to appease you because it's not going to change anything. They should be able to educate you as to what's going on. Do they offer some options for treatment? So you should come away knowing that there's 3 options, either a procedure, D&E, to try to soften and ripen the cervix and deliver, or to maintain the pregnancy until you go into a natural labor. Do they refer you to a genetic counselor or maternal fetal medicine for additional, I say. So they shouldn't be turfing you off and saying, well, I don't know, go see the specialist. It should be in collaboration with the specialist and really just forming trust there. These are typically not genetic predispositions, so genetic counselor is not necessarily the most appropriate. And do they make sure that they also offer expectant management? They offer you the option to carry to term, especially given your shared beliefs around abortion. And there is a link here. So if you want to know a little bit more about anencephaly to help you get into character and understand, there you go.
And we'll go over this again in the morning when you all are here. Just real quickly, the sort of outline for the day in terms of timing, so you have a sense of that. You guys are going to arrive here at 8:30. That will give us time to pre-brief some of this information that we've gone over today. Your first case is 8:30. Your cases are 20 minutes apiece, followed by 5 minutes of feedback, followed by a 5-minute break.
Hey, Chris.
Yes.
You said they're arriving at 8:30 and their cases start at 8:30?
No, they're arriving at 8 o'clock.
Oh, okay.
Yeah.
I was like, wait a minute, that's
Yeah.
a really fast
No,
turnaround.
no.
Okay.
You come in at 8 o'clock, get your pre-brief, so we can square you up by 8:30 when you start. You are in total doing 6 rounds. There's 2 groups of students who are rotating to each of the 3 cases. For you, that will just feel like 6 students. So the day goes from 8:30 until 11:25 when the last feedback session ends. 11:30-ish. Any questions about that? In that case, if you don't have any questions for Erica or us, free to go. Remember to give yourselves an hour today for the training. I'm looking forward to seeing you next week. April 15th at 8 a.m.
Next day.